Hi, I'm Gavin Giovanoni.
Hello, I'm David Baker. Welcome.
I'm Gavin Giovanoni.
Hello. This is our first Google Hangout. We are broadcasting live from wintry London, and we welcome you wherever you may be in the world. Just so you can know, if you're watching on the YouTube channel, there is a little thing called chat. So if you want to ask us questions in real time, then please do, and hopefully we can see those questions and we can respond to them so it's live. But thank you also for the many people who've actually already sent us some questions about what we're going to do tonight. And say, this is probably the first of a few. Let's see how it goes. And what we want to do is talk about different things that are occurring in the MS research world. And today we want to focus on something that's quite topical, and that is hematopoietic stem cell therapy, which is HSCT. And that is interesting because we've had a paper quite recently produced by a group of different individuals who have randomized people to their current DMT, their drugs, or to stem cell therapy. And the results are very interesting. So I guess first thing is maybe we can ask Professor Giovanoni just to actually tell us roughly what this trial said.
I think the big criticism in the HSCT space has been that there's never been a proper randomized controlled trial. In other words, what can we compare the results of HSCT to? The Italians did try to do a trial, HSCT versus mitoxantrone, but they had to stop the trial prematurely because they couldn't recruit. And the reason they couldn't recruit, that all the neurologists putting patients into the trial thought they didn't have equipoise. In other words, they were already convinced that HSCT worked. But even when they stopped that study, the HSCT was superior to mitoxantrone on MRI outcomes, but there wasn't sufficient number of participants to have an outcome on clinical. And so this trial, the MISS trial, is really important because this is the first randomized trial where people were breaking through another DMT in terms of relapses and MRI activity, and then they were randomized to either go to HSCT or to another DMT, and the DMT was left up to the clinician to choose. What you've got to realize is this trial was done, started in 2005, so back then there wasn't very much available. There was interferon, glitterum acetate, and natalizumab essentially, so that was kind of the majority of treatments. But there was an escape clause. In other words, if you broke through on the EMT, you could always access as an escape rescue therapy HSCT. And this was a 5-year set of results, which and so this is really the first randomized. Unfortunately, it can't be double-blind because you just cannot blind people who've had HSCT. So there is this issue whether or not there's a blinding issue, but the results are pretty striking. People who had HSCT did so much better.
Yeah, so I guess we also have to put it into context. I guess people did do a lot better, but in terms of the DMTs, was it kind of like for like? Was it the quite potent DMTs or
No, it wasn't, because a lot of the patients went on to what I would call platform or first-line therapies, which would not happen in the current era. There were quite a chunk of people who went on to natalizumab because it was in that era when natalizumab was being prescribed. But even in the subgroup analysis of the HSCT, it was superior to natalizumab. But I think nowadays, if we had to do this trial, and we need to do another one, to be honest with you, because the playing field has changed. We really would need to compare HSCT to our bucket of very, very high efficacy therapies, particularly against alemtuzumab. And the reason why I say alemtuzumab, because alemtuzumab may be viewed as a form of HSCT in a sense. It's an immune system reboot or immune reconstitution therapy, and we think works in a similar way. Maybe you should just explain how you think, David, HSCT works.
Well, I mean, obviously, how I think it really works. I guess, first of all, we have to go through the mechanics of what is HSCT. And essentially, it's just a glorified name for a bone marrow transplant. So historically, somebody would kind of draw the bits of bone marrow out from the center of your bones, and that's where the stem cells that will make white blood cells live. And this is the idea, is that you take those type of stem cells and they can make any of the immune type cells. So you do that. So it's moved on a bit forward from that. So we don't now have to kind of drill into your bones to get those cells out. So what first of all you do is you use drugs to mobilize those stem cells. So you get them so they come out of the blood, and then you can collect them. And the cells are called CD34 stem cells. And then you kind of get them, you collect them, and then you kind of grow them up, and then you kind of freeze them. And then you go in with a drug that will cause the ablation of the immune system. So you clean the bone marrow out, you try and clean the spleen and the lymph glands and the blood, and then you replace the immune system with these stem cells, and they can grow and they repopulate. And there are different ways of how this works. So obviously one of the main things that the stem cells do is they produce white blood cells that will fight infection, because you're at great risk of infections if you don't have any immune system. And so that is one thing that they do. Now, there are different types of hematopoietic stem cell therapy. One is called ablative, where the idea is actually you remove the immune system completely, and the stem cells will act as a replacement system. They will get into your bone marrow. They will start to make a whole new immune system. And so you're starting potentially from day zero, except we have to remember that many of these drugs that we use to get rid of the immune system don't necessarily get rid of what's going on in the brain. And that may be why we sometimes see failures of these treatments. And then you generate a immune response, but it means you haven't seen any of those infections that you've seen in your childhood. And so you'll be susceptible to measles and rubella and mumps and all those things unless you get vaccine. So there's a lot of kind of work that has to go behind that approach. Or alternatively, you're using the stem cells as really as an anti-infection control. And the idea is that you use a drug to get rid of or reduce the immune system to a level that's actually probably in excess of what we're doing with the current MS drugs. But obviously, it then removes the white blood cells that protect you from infections. And so you are at risk from an infection, and therefore you have to get those stem cells, and you have to wait for those stem cells to grow up, and you're at risk from infection. And that's why some people, take these things in the bubble, as it were. And that's the different type of the stem cell approach. And of course, the question is do you need the non-ablative? Does it actually work better than the current DMTs? And I guess the question is that we don't really know. And the reason why I say that is, although we look at the results and they say they were very good, I will throw it back maybe to Prof G and say, well, the alemtuzumab phase 2 data was probably almost equally fantastic, I think.
Yeah, so I mean, until we actually do head-to-head studies and compare them, we won't know. But I think, but even in the non-myeloablative, David, there's different levels of ablation. So what you've got to realize is once you've harvested these stem cells, you then use chemotherapy to wipe out the immune system and replace it. And so you can go from the ablative, and the problem there is serious toxicity associated with the ablative protocols. And even in the non-myeloablative, there's different levels of intensity. And that's one of the issues we have with some of these bone marrow units in other countries, is when you get back what these people have been given, is they're not being given nearly enough of the cyclophosphamide as the drug we use to ablate. Maybe given what we would call very intermediate or low dose cyclophosphamide. And some of these protocols ask these patients to come back and receive ongoing rituximab. So it's kind of like a bit of a fudge what HSCT means. So I suspect the international consortium that does this should come up with a protocol where they actually say, what would they consider as ablative, non-myeloablative, and what would they consider outside the true and non-myeloablative. But as you go up the tier, it looks like the efficacy gets greater, but the risks get greater. And that's the biggest issue, is while you're waiting for that bone marrow to recover, people die from infections and complications less often than they used to now, because the recovery rate now happens quite quickly, within 2 to 3 weeks, and you get good bone marrow support. In other words, antibiotics to fight infections, platelets if you need platelets for clotting, and all those types of things. So the transplant teams now are so much better at looking after these individuals who have had HSCT that the mortality rate has plummeted. So I think it's getting much, much safer. It's still a procedure though, and people get quite ill and during the procedure. And that's another issue, is most countries now only offer the treatment, most units only offer the treatment to people that are less disabled, so early MS. Because once you become more disabled and you have urinary catheters or urinary tract infection, that puts you at a higher risk of the complications. And also the chemotherapy sometimes is neurotoxic, so people come out of the procedure worse off than when they went in, because the brain and spinal cord can't handle the infectious complications and the chemotherapy, and they often deteriorate. So it's there's a big risk-benefit balance here. But we need, and here in the UK, we're hoping we're going to get the trial funded and started, where we will be comparing alemtuzumab versus HSCT. And it's not just about efficacy, it's also going to be about risk profiles. Which one is safer than the other one, because you have to balance risks and benefits. And the other thing will be cost effectiveness. One of the questions that came through today is how cost effective this is. And based on our current NHS prices, it's probably one of the cheapest countries in the world to do HSCT in the UK. The whole thing costs about £30,000 on average. And when you compare £30,000, say, to alemtuzumab, just the drug costs in year 1 are £35,000, and in year 2 another 21, and that's without the VAT. So we're talking, half the price of just the drug costs of alemtuzumab. So it'll almost certainly be more cost effective than having to use high cost drugs.
Does that mean we have to set up whole new units?
I suspect so. One of the questions is it likely to be offered across all areas of the UK? Well, it should be, because right now we have the ability to use HSCT, not under the MS guidelines. If you go under the bone marrow transplant unit guidelines and you look at each bone marrow transplant unit has about a 15% discretionary rate to use HSCT outside of oncology indications, cancer indications. And on the list are autoimmune diseases, and one of them is MS. So right now, almost every established bone marrow transplant unit in the country has the ability to treat people with multiple sclerosis. Now, the block there is not the bone marrow transplant unit. It'll be the neurologists or the MSologists referring into that unit for that. The hematologist is not going to make the decision that you need a bone marrow transplant. It's going to be the neurologist, and the neurologist is going to have to refer. And so that's why we have got quite strict guidelines. In the London area now, we have a multidisciplinary team meeting where all the cases have to be referred. And we have quite strict guidelines in terms of age, how much disability there is, how active the patients are, and what they failed to be put forward for the bone marrow transplant unit. And there's several units now in London that offer this procedure. There's Imperial College, King's, UCLH does it as well. I'm not sure if they've been doing it in the NHS, but they definitely do it privately. And there's some private units as well. And our unit has just started this week, actually. Our first patient went through the HSCT unit. So this is an emerging treatment option that's going to, I suspect, become much more common across the country.
So how do you think we get neurologists to get on board? Because if that's part of the roadblock, how do we change the vision of people who are kind of risk averse and don't want to go down this path?
If I said it's how long is a piece of string, then you're going to say twice as long as double it, and it's twice as long as it's but by doubling it. But it's the old story. How do you get people to adopt new technologies? And this is not a new technology. My personal opinion, the evidence right now is overwhelming that this is one of the most effective treatments we've got. But I think because of the risks now, we're pigeonholing those people that have really got bad MS into it. Hopefully, if we can show that it's cost effective and the risk-benefit profile is equivalent or even superior to, say, alemtuzumab, then I would suspect more and more MSologists will refer in. And I suspect more people with the disease will want the treatment.
So I'm going to put that Prof G on the spot now, because we've had a question. It says, which cases would Prof G refer to HSCT?
Well,
or autologous HSCT, I guess.
Yes, we know about autologous. We're not talking about allergenic. Allergenic is when you get the stem cells from a donor, and we're not doing that because that is far too risky. And actually, the evidence base for that is pretty weak in a few cases. So talking about your own stem cells. Yes, at the moment we've got people with early MS, so the disability score has to be below 6, so they're not using walking aids. And my personal opinion is they shouldn't have recurrent urinary tract infections or urinary catheters inside, because that's a source of infection. They also should have, at the moment, failed a high-efficacy drug. That could either be first line. So we have put forward somebody who's failed alemtuzumab, actually, to go for HSCT, and they had that first line. Or they must have failed 2. One of them has to be a high-efficacy drug to go forward. And then there's also an age cutoff, and the age cutoff is not strict. It's around about 50 to 55. And the simple reason for that is the older you get, the less well you tolerate these procedures, and the risks go soaring up with age. And actually, the guidelines are on the website. So we have posted on our blog. If you search for HSCT, you'll find the London guidelines, and that'll disappoint some people. One of the questions, though, is what type of person it is. And in the past, we limited to relapsing multiple sclerosis, but we have been. I know some of my colleagues have been putting forward people with active primary progressive disease. So these are people that have activity on their scans, gadolinium-enhancing lesions, a new lesion load, and quite rapidly progressive. As you know, we have no treatments available for primary progressive in this country. And so if you have got primary progressive disease and you are getting worse quite rapidly, there's no reason why you couldn't be put forward for HSCT under the current guidance.
So that's kind of not quite saying what Professor Burt was saying. He's saying, obviously, if you have progressive disease and thinking about going away to these treatments, that your chances of success are reduced. I
think you were saying that's all our therapies. The more disabled you are, the more advanced you are in terms of your disease, the less likely you are to see a dramatic response. And so it's got to do with reserve. So in this trial, almost the majority of patients actually improved. The EDSS scores got better. So that's the difference between the DMT arm versus the HSCT arm. People actually saw their EDSS scores get better, improve in function rather. And we've also seen that in about 35 to 40% of people having alemtuzumab. So it'll be very interesting to see the head-to-head. Mm-hmm. David, there's a question here about do these stem cells, because they are stem cells, go to the brain and repair damage?
Well, I think my short answer is probably no, because they're not the type of stem cells that we think of. When we think about stem cell therapy, you think about remaking nerves, remaking oligodendrocytes, and that will then turn back the clock. These stem cells are stem cells that kind of make white blood cells. They don't really make nerves. And so if you're thinking about they're going to repair everything, I think we have to think again. What we can think of is that it may stop the clock, and that will allow the natural capacity of the brain, because it has one, to repair. And possibly that's the question we can argue about, is what we've seen with certainly with some of the effective DMTs, is that people's scores get better. And the question is that because the drugs cause nerves to regenerate, or is it simply that by stopping the inflammation in the brain, it allows the natural repair mechanisms to kind of do their job and repair? So I think what we should say is the best thing is you stop the clock as early as you can, and then allow the natural capacity to repair. We shouldn't make any claims that it's going to be reverse the symptoms. So it is a very different to the stem cells that many people kind of envision, which is the ones that will kind of reverse the deficits. That's more science fiction. We can do some things in the lab, but in reality, you know, the effects are modest. You know, they're not going to turn back the clock instantly. So the best way of dealing with MS at the moment is to actually stop the damage occurring in the first place. And that's obviously one of these this type of treatment is something that can certainly stop the clock as a good type of treatment.
Yeah, so I mean, it's the same message again with HACT. The earlier you use the therapy, the better the response, and what predicts recovery will be young age, because the younger you are, the better you recover. And reserve, so the more nerves that are there in the beginning, the more likely you are to recover function. As soon as you get older and you've lost reserve, in other words, you become disabled, the chances of responding to HACT in a dramatic way is reduced. So this is one of the problems we had when we had that BBC program about that case in Sheffield. There was somebody who had an acute major spinal cord relapse, young person. They had HACT and got up and walked from a wheelchair. Well, the reason they got up and walked because they were recovering from a major relapse. And they probably would have got up and walked regardless of whether they had HACT or not. They would have probably recovered function if they'd been given alemtuzumab or natalizumab. Any therapy that would have suppressed inflammation and allowed recovery.
So that's, be warned when you see all these wonder cures on the media, is to actually try and understand there is a story behind that, and it may be not a wonder cure. It may be just part of the natural history and recovery of the disease process.
So there's a big thing about toxicities. I think, for the sake of time, there's a detailed blog post we did on this, talking about the acute toxicities. But I think the one that really comes up is this one about for starting a family. So one of the things we use to ablate the immune system, first of all, we use this drug called cyclophosphamide in most of the protocols. First of all, to harvest the stem cells, you just do a mild depletion and it allows the stem cells to proliferate, and then you mobilize them with a growth factor. And then once you've mobilized them, you deplete with cyclophosphamide. Now, cyclophosphamide is toxic to the ovaries. So it damages the ovaries and the testes potentially. So if you're a male, you'd have to sperm bank. If you're a female, the risks depend on your age, but the overall risk of becoming infertile, in other words, going into premature menopause, is quoted by most units as being between 40 and 50%. So this is a big downer on HACT for women. And so to overcome that, you probably would have to, if you wanted to have children or start a family, extended families, you'd have to donate eggs. And that would delay HACT. And most people who need HACT need it quite quickly because they've got very active disease. Harvesting eggs is not a trivial procedure. It takes several months to induce ovulation, harvest the eggs, and then freeze them down. So yes, the biggest, in my experience in practice, the biggest reason why people say no is when you give them the risks of infertility, they say no. And this is a chemotherapy agent. It's just part of that space. It's a cytotoxic therapy, and it hits all dividing cells. So that's why it hits the testes. The ovary is actually, the eggs are actually post-mitotic, but they're still susceptible to the effects of cyclophosphamide, which actually cross-links the DNA strands and causes the oocytes, the eggs, to die. So a big downer. And also you're going to get all the other things. You get the nausea, you get the hair loss, the infection risk, the mucositis, in other words, that affects the dividing cells in the mouth. So you get extremely sore mouth. It happens in the gut, you get diarrhea. So all those side effects that we know that happens with chemotherapy happens in this. This is why people get quite ill with the procedure.
We actually had a question which kind of relates to side effects as well. Is there an increased risk of PTLD or EBV infection after HSCT? And do you think that MS patients that undergo would have a greater risk of PTLD? So
it's post-transplant proliferative disease. So post-transplant means when you suppress the immune system to such a degree, your EBV causes the B cells to form like a lymphoma. They proliferate crazily. And actually, with the non-myeloablative, it's a low risk. Often we do see in a significant number of patients Epstein-Barr virus reactivation, but it's never severe enough to cause post-transplant proliferative disease, because what happens is the immune system recovers quite quickly and fights that off. And the other one that happens is CMV reactivation. So the bone marrow transplant units will pick that up and measure it. They may have to give an antiviral to suppress the cytomegalovirus that lives in the body. And then you may get herpes infections, and they put on antiviral prophylaxis to prevent herpes infections. So those are less of a problem, chickenpox and herpes. EBV, we don't have a drug for EBV, but it is manageable. So in this space, all those complications that occur when you get bone marrow transplant, which is usually myeloablative for cancer therapies, are less severe in this population.
So a good question for Prof G, who's a big fan of the EBV. Is there any evidence that EBV and this proliferative disorder is associated with a worse efficacy?
Well, we don't know that, because that's one of the questions we would like to ask in the trial we're proposing to do, because actually the people the hematologists who run the MS said they get much more EBV reactivation in the MS patients than they do in the other oncology patients and other autoimmune diseases. So there's something specific about MS, is that they see much more EBV reactivation than they would expect at a population level. Whether that has got to do with MS, I mean, it seems like MS, people with multiple sclerosis, has got a problem with EBV, and this just may be another manifestation of that. But you know the data better than me. Those people tend to recover their B cell function much quicker than the people who don't have that. And that may be a marker of non-response, because if the B cells are driving some of the pathogenesis, some of the MS activity, then if they come back too quickly, you may get a failure. But that's a question that's going to be asked in a future trial.
So good question. There's another question here that we've got, and it's talking about efficacy of Lemtrada, Ocrevus, and stem cells, and best treatment. That's kind of not so much the point. The point is, this question is why is Ocrevus only available on the NHS if Lemtrada fails or can't be used? So does Prof G want to kind of get into the economics?
So that's just based on pure economics. As you know, ocrelizumab is given every 6 months indefinitely, and so there's a fixed cost, and it accumulates over time. Whereas alemtuzumab is given as 2 courses, year 1 and year 2, and we now got permission to use a 3rd course. And so you've got these, and that's it. And most people, in inverted commas, go into long-term remission. And so therefore the cost benefits over a 10, 15, 20-year horizon look very favorable. And so when the cost benefit analysis was, alemtuzumab was considered to be more cost effective. So therefore we should offer it first, and people should have that as a first option, and only if they don't want it or their contraindications should we use ocrelizumab. And so my personal threshold is low for using ocrelizumab in that scenario, because a lot of people don't want necessarily want the risks associated with alemtuzumab therapy, particularly the secondary autoimmune diseases, which is another issue. It's kind of played down. But if you look at the small print in the HSCT data sets, secondary autoimmunity is also noted post HSCT. And I think for the same reasons, is when the immune system reconstitutes itself, it comes back awry, and we're not quite sure why it comes back in a different way, but there is a risk of secondary autoimmunity post HSCT. It's probably not as high as with alemtuzumab, but I would put it I'd put it at about 1/3 of alemtuzumab, and it includes not only ITP, but it includes autoimmune thyroid disease and all the others. So that's, which also has implications for monitoring, because at the moment most people don't do the regular monitoring we do with alemtuzumab, which means you've got to come up every month for a full blood count to make sure your platelets are normal, and a urine test to make sure you haven't got kidney problems. And I think we're going to have to build that into HSCT monitoring, is that actually secondary autoimmunity is a problem, and we should put them onto the same monitoring protocol as alemtuzumab, I would expect.
I mean, in the protocol, they use a rabbit anti-thymocyte drug. Does that mean it only targets T cells and thymocytes, Prof G? No.
I mean, I think it's a polyclonal antibody, and so its target is multiple antigens. I mean, I can't remember the antigen specificity. Because
what they do is they inject a rabbit with T cells, and then it makes antibodies against the rabbit T cell. Against the human T cells. But those T cells will share many of their targets with B cells as well as T cells and other cells. So it won't, I guess, just be the T cells.
And one of the side effects noted with this particular protocol is not everybody uses anti-thymocyte globulin. There are different protocols. But anti-thymocyte globulin, because it comes from a rabbit, you can actually have what we call a serum sickness type reaction. And that can be delayed. So some of the patients in this trial got a unexplained fever, usually a few days after the ATG, the anti-thymocyte globulin, which was probably driven by the serum sickness type reaction. So that's another safety problem with using ATG, but that clearly works. And it was managed quite comfortably using high-dose corticosteroids to manage that. We've covered most of the questions. Vaccinations and travel, David. What do you think about vaccinations?
Well, I think obviously, again, it depends on the type of HSCT. So if you have the ablative one, then you probably will have to go back to have all your childhood vaccines, I guess. But the question is talking about probably also live vaccines. And I guess when you have a low immune response, then you don't want live vaccines, because there are bacteria or things like that which could potentially proliferate and do harm. So what you have to do is obviously wait till your immune system repopulates before you could consider those type of things, I think.
Yes, I think once your immune system has reconstituted, a live vaccine should be safe. And so you've got to wait for the immune system to come back. The question about revaccinating with childhood vaccines, depending which unit you go to, there is no consensus on whether this should happen with non-myeloablative. I think with myeloablative, it's pretty obvious you have to be revaccinated. And some people do it towards the end of the first year. Some people do it in the second year. I think with non-myeloablative, the question is unanswered whether you need to do it. But my personal opinion is you don't want to put people at risk of getting childhood infections. So you probably need to screen them to make sure they've got antibodies. If they haven't got antibodies, they need to be revaccinated.
And what about traveling after HSCT?
Again, the same thing. You wouldn't want to travel while you were still immune depleted. So that's for the first 4 to 6 months while your counts are down. Once your immune system is reconstituted, it is competent. You have the ability to mount immune responses to new infections, to vaccines, and you've got tumor surveillance intact. So there, I think it's fine to travel. No reason why not to travel.
I suppose that's also one of the potential worries about when people go to different countries for their HSCT, that they probably may stay there for a month, but then after that, you have to get back to the UK, and you're traveling through airports with and you're maintaining a plane where you get the air circulated around. So
and you also need to be monitored quite closely, even though a lot of our patients who've actually gone for HSCT abroad have come back quite quickly after the procedure, where they may still get complications, and so it's very important that you don't just do this without at least informing your general practitioner and your neurology teams. I'm not going to not look after one of my patients who goes away with this, but I would like to know about it. If they do develop complications, we're prepared for it. We would encourage you not to do it, because we have no idea of the quality. That's another thing you've got to be aware of, is the bone marrow transplant units in the UK are accredited. In other words, they have to produce figures about how good they are in terms of mortality, how many people die from the procedure. They have to have special protocols in place around hygiene and looking after people. So they have to be accredited to do it. And to be accredited, you've got to have quality metrics. And so a lot of these units have no quality metrics. So you can't be guaranteed of how safe they are. And also you can't be guaranteed about what protocol they use. So we discourage all of our patients going abroad for HSCT. If you want HSCT, you're much better off trying to access it via the NHS, where you're going to be put through an accredited unit that's got a good safety record.
But how easy is it to get HSC in the NHS?
So we as a community are not denying people HSCT. We're saying there are issues that are unanswered in terms of its safety and efficacy. But if people have got highly active disease, there are ways of being referred to an accredited unit to be offered under the NHS, covered by the NHS in terms of funding, etc. So please think carefully about going off to an unaccredited or non-accredited unit in another country.
So are we thinking of doing some trials in the UK?
Yes, so there's a consortium. We put up a proposal several years ago called the Zeus trial, and that's moved forward quite a lot. We're not bone marrow transplant experts, so the Sheffield group, John Snowden and Paula Marara at Imperial, are leading the grant application. And cross fingers it's going to get funded by the NHS, and we will start a trial in the next 6 to 9 months, and then it'll be open to the whole of England, because it's an NHS England initiative, and we'll be able to once and for all test in a randomized, controlled way, non-myeloablative HSCT versus alemtuzumab, and possibly we may need to change the guidelines to include other therapies, like ocrelizumab as well. That's under debate amongst us at the moment. But I can't promise this is going to happen, but it's hopefully going to happen in the next 6 to 9 months. Cross fingers. There's one last question we need to ask, David, answer before we check off, is the mortality associated with this, because when depends where you read, you get figures of up to 6%, and I think the 6% figures are historical. They're based on the European registry, and if you look at EPOC, the mortality rate's coming down, and most people would say now the mortality of this procedure is 2% or lower, and that's a conservative figure. When you actually drill down, it's below 1% and it's below 0.5% in the best units. And so most of the, and also that's also autoimmunity in general. So when you go to the MS population, they tend to be healthier physically. And so the mortality rate is probably closer to 0.3%. That's 3 people in 1,000 will die as a result of HSCT. So it is not a trivial figure, 0.3%. But it's something that needs to be kept in mind, that when you have HSCT, you're putting yourself at risk of the complications. I mean, the good thing about the MISS study, there was 0 mortality. And so, it is showing that in a highly motivated group of clinics managed well, the mortality rate is very low.
Is it guaranteed to work?
No. I mean, so that's another thing, is people expect this to be a cure or 100% effective. And it's not. It's like all immune reconstitution therapies. There's a very good response rate. Let's talk about a response rate at 3 years being 80%, so 20% would have broken through. And every year you follow up, more people break through. So over time, there is an attrition rate. But overall, the needle rates there's been a meta-analysis of this by Maria Piersamani that was published 2 years ago now, showing you that it was really superior to all the other therapies in terms of NIDA, no evidence of disease activity. But again, the attrition rate happened every year. And so you shouldn't go into this procedure expecting it to be 100% effective. It doesn't. It's very effective, but there'll always be people breaking through. And whether it causes a cure, time will tell. I mean, it's too early to say. I mean, the best cohort for this is the Canadian cohort that have been followed up for now over 10 years. They were given myeloablative, though, and those patients are doing remarkably well in terms of inflammatory activity. There are a portion of patients that are getting worse, but that may be other mechanisms driving worsening rather than active MS. It could be age-related phenomena, previous damage working its way through the system. There are lots of other reasons why you can get worse despite having HSCT.
I mean, there's another question. Do we have any data on atrophy and brain volume and grey matter volume?
Well, I mean, the best data there again is from the Canadian group, and it is the best, unfortunately. I mean, in terms of unfortunately or fortunately, it is the best. And one of the problems about the trial, though, is people took a big hit in the year 1, so they lost several percentage points. And that could be switching off the inflammation. You get pseudoatrophy as the brain shrinks. But it would also be neurotoxicity of the chemotherapy causing acute neurotoxicity. So you get this massive shrinkage in year 1. And then after year 1, the percentage brain volume loss was almost in the so-called normal range, better than all our therapies. And so you've got to take this potential hit up front. So it's what I would call front loading of risk to get the benefits. So it is now with the other HSCT, I suppose there, as we said, it's a bag. You've got shades of grey, and I would imagine the impact on brain volume will get less impressive the lower down the efficacy scale we go. And but it's not all of. I mean, I think we need to just be open-minded about the results of the HSCT on brain volume loss, because not all the studies have reported brain volume. And so the one that has reported happens to be myeloablative. So we can't extrapolate the Canadian results to the other cohorts.
Yeah.
I think we've covered everything, David. Any other questions? People are asking about relative efficacy. Well, I don't want to put myself on the line and say HSCT is going to be better than alemtuzumab. We're doing a trial, or better than ocrelizumab. Depends what the outcome is. Most of the trials we are designing is what we can measure: relapses, disease progression, brain volume loss, new lesions. But that may not be what's most important. What may be more important is, for example, what does it do to the slowly expanding lesion? We think now that this particular lesion, which is a chronic active lesion, is causing a lot of damage in people with more advanced disease. I sent an email to Doug Arnold, who's got more data, and he just sent back saying, we just don't have that data. We have no idea what HSC does on the slowly expanding lesion, and we have no idea what alemtuzumab does on that. So hopefully, as part of the future trial, we'll be able to look at both alemtuzumab and HSCT's impact on that particular question. What's it doing to whole brain, relative to each other? Gray matter, which is probably more important than whole brain, and what it's doing to that slowly expanding lesion. These are what I would call end organ markers. So more to find out about the relative efficacies of these treatments.
But it does show us, I think, very clearly that the immune system is instrumental, at least in driving the attacks in MS. So I think, and that's why obviously one would think that HSCT has potential, because you're actually depleting the immune system to such an extent. The question, of course, is, do you need to reduce it as much, or alternatively, can we get smarter and work out which bits we need to remove? Because I'm sure we don't need to get rid of everything.
Well, I mean, I'll never forget when I first started in MS back in 1993 when I arrived in London. I went to a meeting in Cambridge, and John Newsom Davis, who tragically died a few years ago, worked on myasthenia, and he came out of a lecture where we were talking about using HSCT and immune reconstitution therapies, and he said to me, we want to get away from it. He said, that's a sledgehammer to crack a nut. What we need is targeted therapies. And I think we as a community need to think about targeted therapy. We cannot realistically use HSCT as a treatment for everybody with MS. It's just not practical, and it's probably not safe enough to do that. So we have to learn from HSCT, try and dissect out what it's doing, and see if we can develop targeted, safer therapies, particularly around the acute infectious complications. But that's the other thing about the hype. Is it overhyped? I think it may be overhyped, and I'll say why. Is history often repeats itself, and we saw this with alemtuzumab. When the phase 2 alemtuzumab results came out, they were unbelievably positive.
They're as good, at least as good as what was reported here. So,
and often when you do the blinded, truly blinded next phase, where you've got a bit of a different patient population, the results may get less impressive. And so, the cynic and the skeptic in me is just saying that, yes, this is very impressive. I have no doubt it works, but it may be more impressive in this trial than it will turn out to be in other populations and other studies. So I just want to put a little bit of dampener down to manage expectations. Yes, this is probably our most effective therapy. However, I don't know if the results are going to be as good as this. I'll be surprised if they're as good as this in other trials.
And that's also, you see the science in Prof. G, because I don't know if you remember, I think, was it about 7 years ago you suggested this type of trial should be done. So, we all have the bright ideas. It's a question of you got to get down and do it, I think.
I think we've run out of time. Actually, we're going over time now. So what this will do is this will be recorded for people who haven't watched it, and it'll be put online, so you can come back to it if you want. What we will do is put a survey online just to see if you like this format, or if we should change this format. And please come forward with any topics you want to discuss. And we plan to do these every 2 to 4 weeks in the academic year. And we could potentially do them more often because they are really easy and to run, and we want to keep them informal. We don't want the Hangouts to be a formal. We want them to be just a casual discussion, and we also have the possibility of expanding and having it live. Bringing a few people who have MS into a room, and we can have the camera set up that we can be interviewed by people in the room. So come forward with any ideas if you want to participate. One
last question was: is there an advantage over Milo and non-Milo? Horses for courses each have different benefits. I mean, probably what we should have done is a head-to-head, one versus the other. That would have been really easy to blind. You'd have known full well at that point whether you needed HSC or not. Probably.
Well, I can tell you why. When we was discussing the original trial design,
Mm.
and we had this question of 3 R's: myeloablative versus non-myeloablative versus alemtuzumab. Even the hematologists on the line were worried about the myeloablative because they know how toxic it is,
Right.
and so they in themselves thought that the risk benefit was too high, and they thought that the non-myeloablative was much safer and easier to do. So for hematologists to say that, it's telling you that it is really a different kettle of fish, different ball game having myeloablative. So I don't think we could realistically offer a myeloablative therapy.
Okay. So thank you for watching us, for those people live and for those people sending the questions. And for those on YouTube, obviously you can still send us questions at the blog, so ms-res.org is probably the easiest one I can remember. I can't remember. Just Google us. Yeah.
Okay. Take care.
All right. Bye.